Hello everyone, we are going to talk about cannabidiol today, or CBD as it's more commonly known as. And we're going to talk about it specifically in the treatment of chronic pain and headache disorders. There's not a lot of data or information out there. It's a bit of a wild west. And so I hope to clarify some of these concepts of how we suspect it may work, some information about dosing, some of the evidence behind it, and hopefully provide a general overview. There's a lot more that we need to learn about it and a lot of research that is starting to happen but needs to happen to be able to give better clarity of a lot of these issues. But hopefully today will give some insight of where we're at currently. So CBD, as you know, is everywhere. You can buy it at the local pharmacies, supplement stores, department stores, gas stations. I've seen it selling at video stores. So this stuff is everywhere. And the questions become, is there evidence for it? What's the evidence? How do you use it? How does it work? And there's just a lot of unknowns. So hopefully we'll piece some of this apart today. I'm going to start by going over a little bit of historical and legal perspectives of CBD use. We're going to review the endocannabinoid system with an emphasis on CBD receptor actions and effects. I'm going to talk about some CBD pharmacokinetics, or how it works in the body, and some potential side effects. I'll summarize some of the evidence for CBD in pain use, which is very limited, unfortunately, right now. I'll go over some clinical use suggestions and some issues with unregulated CBD products in the market that it's really important to be aware of. And I'll clarify some common CBD misconceptions at the end here. This is a talk that I did for our Cleveland Clinic neurology for our headache grand rounds lecture. So I'm adjusting it a little bit today to make it a little more understandable in terms of layman's terms for the public, but also it'll still remain, somewhat scientific, so it's good for the medical community as well. So to understand where we're at with CBD currently, it's important to understand where we came from and how we got here. So CBD comes from the plant cannabis, as I'm sure you're aware, and the medical use of cannabis dates back thousands of years, centuries. It was used centuries ago for childbirth pains and rheumatic pains. Fast forward very far to 1839, Dr. O'Shaughnessy first introduces the Western world to the use of Indian hemp, as he called it. Later was known as cannabis indica. And this was after a professorship in Calcutta, India, that he did, where he learned of the plant. He was a strong advocate of its use for pain and muscle relaxation. Through the late 19th and early 20th centuries, cannabis-based preparations were being pretty widely distributed and made by several large pharmaceutical companies. Some of the companies are still in existence today in the U.S., not making these products, obviously. But they were listed in the U.S. dispensatory in 1845. Many prominent physicians were prescribing cannabis for episodic and chronic daily headache, migraine. They were using it acutely and preventatively, and they were using it for a lot of pain purposes. And for those neurologists out there, there's a lot of famous neurologists that are well known. Dr. Gowers, Weir Mitchell, Sir William Osler, who is the father of modern medicine, was recommending cannabis indica in his famous textbook of those times for the treatment of migraine. So it has a rich history, and that can be talked about in a different talk that I've done that you can listen to separately. Today we're going to focus a little more on just the CBD perspective. So the Marijuana Tax Act of 1937 happened, and this gave large fines and prison time to anyone involved in the cannabis industry. The American Medical Association strongly opposed this bill, interestingly. In 1941, cannabis preparations were taken off the U.S. Pharmacopoeia National Formulary. And then the final nail in the coffin came with cannabis prohibition, and this happened with the Controlled Substances Act of 1970. This is essentially what changed cannabis to its Schedule I status, and it's remained there since. So it's been there, since 1970. The Assistant Secretary of Health, Dr. Edgeberg, at the time, his reasoning for this Schedule 1 status was basically there was a lot we didn't know about this plant, the active components in the plant. He felt that it should be Schedule 1 until we could at least complete some studies to understand a little more about it. So subsequent to that time, we've had quite an extensive amount of studies globally, and in January of 2017, the National Academies of Sciences, Engineering, and Medicine put out this huge publication in Washington, D.C., and this was a quite impressive paper, and they looked at greater than 10,000 high-quality primary research studies, and this was a rigorous review of these relevant clinical scientific research studies published between 1999 and 2016, and they basically came up with 100 different research conclusions on the use of cannabis for a variety of reasons, including pain. For us, the conclusions for chronic pain treatment was that the use of cannabis for the treatment of pain is supported by well-controlled clinical trials, and there was conclusive or substantial evidence that cannabis or cannabinoids are effective treatment for chronic pain in adults. So this was their conclusion based on their analysis of all these studies, and this is a publication that you can refer to. It's quite useful, actually. The number needed to treat through a lot of these studies for pain benefit with cannabinoids tends to be about 3.4. So for every 3.4 patients treated, that person tends to get benefit, for example. In 2014, the Canadian Pain Society revised their consensus statement recommending cannabinoids as a third-level therapy for chronic neuropathic pain. And there's this thing called the cannabis entourage effects. And the thinking here is that the synergistic action of the major and minor cannabinoids, the terpenes, other compounds work together for therapeutic effects of cannabis rather than each individual component. So the question for us at this point becomes how much of these therapeutic benefits are purely from the CBD component? And that's the question that we're dealing with right now. So let's review the endocannabinoid system. This is a system that is inherent to everyone. It is widely distributed throughout the central and peripheral nervous system. It plays a role in many regulatory physiological processes across all organ systems. It plays a very strong role in the pain pathways, and it's comprised of cannabinoid receptors and endocannabinoids or ligands, which bind to the receptor. So the CB1 receptors, or the cannabinoid 1 receptors, are found more centrally than peripherally in the nerves. They are the most abundant G protein coupled receptor in the brain, and this is a common receptor that's seen in neurological processes and other processes. And it works by a retrograde mechanism. It modulates many inhibitory and excitatory neurotransmitters with activation. It's very densely located, these receptors, throughout the central and peripheral nervous system pain pathways specifically. And these include areas that are well known to headache and migraine and pain, such as the periaqueductal gray matter, the rostral ventral medulla, and in a lot of areas that are known in the pain pathways, which I won't bore you with too much here, but also in the peripheral nerves. The CB2 or the cannabinoid 2 receptors are found more peripherally than centrally. These are also presynaptic G protein coupled receptors similar to CB1. They have a strong role in the immune and the hepatopoietic or the blood systems, and they have a strong role in inflammatory processes. The ligands are the endocannabinoids. These are what attach to the receptors, and our body produces these naturally. These are arachidonic acid derivatives. They are synthesized on demand, so as the body needs them, they are produced. And they assist in upregulating or downregulating the release of presynaptic neurotransmitters. The primary mediator of endocannabinoid signaling is known as anandamide or AEA. This is taken from the Sanskrit word ananda, meaning joy or bliss or delight. This also accounts for the runner's high, which used to be thought of more of an opiate system, but it actually turns out to be partly the endocannabinoid system. This is a partial agonist at the CB1 more than CB2 receptors. It's a partial agonist at the TRPV1 receptor, which is the capsaicin receptor, and it is broken down by its own enzyme that breaks it down. The second primary endocannabinoid is one called 2-AG. This is a full agonist, so it activates CB1 and CB2. It promotes inflammation when it activates CB2, and it's proposed to contribute to some inflammatory conditions based on continuous state of pain and hyperexcitability of the nerves in that area, such as in rheumatoid arthritis. Anandamide is the other endocannabinoid I mentioned. It downregulates inflammation when it binds to CB2, so they actually work in contrast to one another, and it has its own separate enzyme that breaks it down as well. So the phytocannabinoids are basically the endocannabinoid equivalents, but from the cannabis plant. They activate and work within our same endocannabinoid system. Cannabis contains more than 100, approximately, major and minor phytocannabinoids, and these are things like THC and CBD, which are the two most prevalent. There's about 200 terpenes suspected, and these also have various qualities of medicinal benefit, such as some of them have analgesic or anti-inflammatory properties, some are very sedating, myrcene, beta-caryophyllene, limonene, pinene, these are some, and these are, terpenes are basically the components that you find in fruits, vegetables as well. They account for the smell, and they account for the smell of cannabis strains, for example. And there's more than 540 distinct compounds within 18 different chemical classes suspected in cannabis. So there's a lot of moving parts to it. So we're going to focus now on CBD, cannabidiol, from here on out. But I wanted to just give some of that background because it's important to know, where CBD came from. So in 1940, a Harvard alumni and a prominent organic chemist at the University of Illinois was named Roger Adams. He first isolates CBD from cannabis. He didn't know what it was exactly, didn't describe its chemical structure. In 1963, Israeli scientist Dr. MacCallum identifies CBD's chemical structure in his lab, and this was in Israel. So he was the first to identify the chemical structure of THC. Also, the following year in 1964, the CBD was 1963. And Dr. MacCallum is known as the godfather of modern cannabis because of these discoveries, and he's still quite active. So CBD is a 21-carbon compound exclusive to cannabis. It is found in the plant as cannabidiolic acid. It goes through a process called decarboxylation, and the end result is CBD. CBD has been shown to have greater than 65 molecular receptor targets. Greater than 80 mechanisms of action have been identified. It's a powerful analgesic and anti-inflammatory. Anti-inflammatory effects have been shown to be several hundred times more than that of aspirin in animal studies. There is no intoxication or no high with CBD. There's no dependence. There's no withdrawal. In November of 2017, the World Health Organization put out a statement that said, in humans, CBD exhibits no evidence for abuse or dependence potential, and there's no evidence of a public health-related concern with the use of pure CBD. In January of 2018, the World Anti-Doping Agency, or WADA, removed CBD from its prohibited list, so this no longer was a banned substance and athletes could use these products. So let's talk about the CBD receptor actions and effects, based on some of the scientific evidence out there. There's really 8 primary mechanisms, and these are specific for pain that I'm going over today. So one of the first and the most common, the most important effect of CBD is that it inhibits the degradation of anandamide, or AEA, our natural endocannabinoid primary ligand. So essentially, by stopping the breakdown of this natural endocannabinoid, it increases levels of this natural endocannabinoid. Anandamide, in turn, is an endogenous, so it activates CB1, CB2, the TPVR1 receptors. We'll talk a little more about those in a bit. It decreases inflammation, and pain relieving. It's an antioxidant. So the second way that CBD works is that it's what's called a negative allosteric modulator or a non-competitive CB1 antagonist at the CB1 receptor. So this doesn't relate to pain, but it's important because the effect here weakens and kind of neutralizes the effect of impaired learning, memory, and the psychoactive effects of THC. So it actually helps to neutralize the negative THC side effects. Third mechanism that CBD works is that it works as an antagonist or blocker and an inverse agonist at the CB2 receptor. And the result here is that it provides anti-inflammatory effects. The fourth mechanism is that it is an antagonist or blocks the GPR55 receptor. This is called the G protein coupled receptor 55. This is a receptor that's normally expressed through the dorsal root ganglia, which are in the nervous system, pain pathways in the spine and the nerves, as well as the brain. This receptor normally helps to modulate the opening of calcium channels on the outside of the nerves, and when this happens, you get a change in the gradient electrically of the nerve, and it causes what's called depolarization, and the result is pain. So these receptors normally transmit pain signals from joints, muscles, skin. They also recruit inflammatory responses in the body when there is some activation of the receptor in these joints and regions. So essentially, the CBD works to block that activity from happening. The fifth way that CBD is felt to work is that it is a agonist, or it activates the TPVR1 receptor. This is known as the transient receptor potential vanilloid receptor 1. This is an ion channel on nociceptive or pain neurons. It releases a neurotransmitter called glutamate when it's activated by the calcium going into the nerve, and the result is that it causes increased inflammation and pain. Capsaicin, for example, activates the TPVR1 receptor, and it causes glutamate release, and so the result is that you get this pain, but then you get some relief following that, which is how capsaicin works. CBD indirectly modulates the TRPV1 receptor by increasing anandamide levels, our natural endocannabinoid, and this modulates the TRPV1 calcium influx into the nerve, but it does it without releasing glutamate. So it actually stabilizes the nerve the membrane, and it prevents pain signaling pathways. And so the result is that you get anti-inflammatory and analgesic effects. The serotonin 1A receptor, CBD, works as an agonist. This is found in some of the brainstem regions of pain, such as the rostroventromedial medulla, and it inhibits pain pathways. The result is that you get some analgesic qualities. It's felt to also influence some of the opioid receptors related to this pathway, and there's also some anti-anxiety effects that have been attributed from CBD to this receptor. The seventh mechanism is it is a adenosine 2A or A2A agonist, so it activates this receptor, and this enhances adenosine concentrations. The result is anti-inflammatory and anti-pain effects. And then the eighth mechanism that I'll mention is a PPAR gamma agonist, so it activates this receptor, and this is the peroxisome proliferator activated receptor gamma. And essentially what this does, this reverses inflammatory vasodilation. When you have an inflammation in the body, you tend to get an increased blood flow, the blood vessels become leaky, you get fluid and swelling and edema in the area. So the effect of CBD essentially is that it decreases the permeability across the blood vessel walls, so you decrease inflammation and swelling, etc. So let's talk about some neurobiology of cannabinoids and migraine. First of all, the spinal fluid of patients with chronic migraine has been looked at and compared to normal controls. What we've seen is that the spinal fluid of patients with chronic migraine have low levels of anandamide. They have high levels of CGRP, which is an inflammatory protein, and high levels of nitric oxide, which is known to cause migraine. So there's been a question raised over time of whether patients that have chronic migraine, and often you see this combined with fibromyalgia and irritable bowel syndrome, and it's felt that this is all just a neurological syndrome. But a question has been raised whether this is an endocannabinoid deficiency within and common to these disorders, and it's an ongoing and an interesting concept. So women with migraine have been shown to have an increased activity of the enzyme that breaks down the anandamide, or AEA. Anandamide has been shown to block the dilation of blood vessels during migraine when it is put in with triggers of migraine, such as certain proteins like CGRP, electrical stimulation, and so it helps to block this dilation effect. And this is reversed, actually, this activity, when you block the cannabinoid receptor, you reverse the ability of it to do this. So there's certainly some connection there. Anandamide modulates glutamate and CGRP signaling, and these are very inflammatory, and these are involved in pain pathway signaling through the TRPV1 pathways. Anandamide inhibits the production of nitric oxide and CGRP, which again are big drivers of migraine. And CB1 activity has been shown to suppress what's called cortical spreading depression in migraine, which is an electrical wave that spreads across the cortex of the brain. When you activate the CB1 receptors in the brainstem, it inhibits the pain sensation through the trigeminal vascular system. So it inhibits the dural and the cutaneous evoked pain fibers. And this seems to have some modulation with the serotonergic system. And specifically, the serotonin 1BD receptor plays a role in this. And this happens to be the receptor of where the triptans work at. So triptans normally activate this serotonin 1BD receptor, and the result is that you break the migraine. So when you block this receptor, it actually blocks the ability of CB1 to do its thing. So there's some kind of a connection as well between the endocannabinoid system and some of the serotonin receptors, including the tryptan receptors, it appears. The CB1 receptor activation in the brainstem modulates the serotonergic firing in an area called the dorsal raphe nucleus in the brain. And it also decreases what's called the trigeminal neuronal tone in the trigeminal nucleus caudalis, which is essentially pain pathways through the brain stem that go into the upper cervical spine as well. So what about the evidence for CBD in pain? Unfortunately, there's not a lot of it out there. There's a few limited trials. A lot of this is more scientific and animal studies. There was a open label single arm study of 12 patients, so very small population. And this looked at the short-term effect of CBD and wrenched hemp oil on chronic pain in girls aged 12 to 24. The chronic pain issues were chronic headache, fibromyalgia, arthralgia, myalgias, GI, gastrointestinal pain. And they looked at a sublingual CBD-rich hemp oil, which was 25 milligrams per kilogram per day. These patients were supplemented with an additional 2 to 5 milligrams of CBD once a week until a maximum dose of 150 milligram supplement was added to their regimen per day. And this was titrated and reached over about 3 months. So at the end of the study, 8 out of 12 patients completed the study, and they all reportedly had significant reductions in body pain compared to baseline, and this was statistically significant with a p-value of less than 0.05 for those that want to know the significant numbers there. There was an open label single arm study with a very low number of 7 patients. This was looking at pain relief and kidney transplant, ages 58 to 75. They used an oral CBD dosing of 50 to 150 milligrams twice a day for about 3 weeks. 2 of these patients had total pain improvement. 4 had partial improvement, and then 1 had no improvement. There was no statistical test applied here, so not overly exciting, but interesting. And then there was a randomized double-blind multi-group crossover trial, so a little bit of a better design. Low population, only 24 patients again, and this looked at pain and spasticity and MS. Predominantly, there's 18 patients with that. There was a handful of spinal cord injury, brachial plexus injury, nerves in the arm, and limb amputation between ages 58 and 75. They looked at whole plant extracts of CBD versus THC versus CBD plus THC versus placebo. And dosing was anywhere from 2.5 to 120 milligrams per day. And the patients were allowed to self-titrate based on effect, based on tolerance. 2 weeks was allowed for each phase of the trial, and then they would cross over to the next part of the study with a different type of combination. And basically, the CBD group had statistically significantly better pain control, again with a p-value of less than 0.005 versus placebo. CBD injections have been injected into arthritic joints in rat models of osteoarthritis, and this was shown to significantly reduce inflammation and arthritic pain and neuropathy within 14 days. There's been topically applied CBD gel on a rat model of osteoarthritis. This significantly reduced inflammation and pain behavior after only 4 days. And then there was oral administration of CBD, which has been shown to decrease serum inflammatory blood levels of what's called cytokines in arthritic models as well. So the evidence for migraine specifically and headache is currently not there. There's certainly some studies and some evidence and some smaller case series, these kind of things in cannabis, but there's no pure CBD studies for migraine. We are in the process of and just about to roll out a study at my institution, along with Dr. Ethan Russo and my other colleague, Dr. Zubair Ahmed. And the title is going to be an oral formulation of Cannabidiol in the preventive treatment of high-frequency episodic migraine. It's going to be a randomized, double-blind, placebo-controlled trial with a better dose of CBD. So we hope to add some evidence and data, whether positive or negative, to try to start getting some better, solid evidence behind CBD. Let's talk a little bit about pharmacokinetics and safety data. So the best model to do this is the GW Pharma medication, the Epidiolex. This is a purified cannabis-derived form of CBD. It was FDA approved in June of 2018 for Lennox-Gastaut syndrome and Dravet syndrome, which are refractory pediatric epilepsy syndromes in ages greater than 2. It's a Schedule 5 medication, and it comes in a strength of 100 milligrams per ml. Dosing ranges anywhere from 5 milligrams per kilogram per day up to 20 milligrams per kilogram per day. What you hear sometimes about CBD is that there's a concern of it elevating liver enzymes. So let's talk a little bit about that. So in these Epidiolex studies, overall ALT, which is one of the liver enzymes, was about 3 times the upper limit of normal. But this occurred in 17% of patients taking the highest dose, a 20 milligram per kilogram day dose, only in 1% of the lower 10 milligram per kilogram per day dose, and overall in 13% of patients on Epidiolex versus 1% in the placebo group. Now, with that said, there are some variables that are important to know. So the majority of these elevations occurred in patients on the highest 20 milligram per kilogram per day dose, and they most often occurred in combination with other anti-epileptic medications, specifically with valproate and clobazam. So when you look at the data a little closer of these patients with elevated liver enzymes elevations, 30% of patients had enzyme elevation when taking both valproate and clobazam together. 21% had it with taking valproate alone. 4% had it when taking clobazam alone, and then only 3% had it when taking neither drug at the high dose. The most common adverse effects in Epidiolex in greater than 10% of patients and greater than placebo was some drowsiness, lethargy, fatigue, somnolence, diarrhea, some decreased appetite, vomiting. But more likely influencing these side effects are a couple other variables. So first of all, most patients were on anti-epileptic medications, and these are certainly big drivers of these kind of side effects normally. So, for example, 18 out of 22 patients on the Epidiolex, the CBD, had somnolence, but they were also on clobazam. And we know that one of the metabolites of clobazam is very sedating. So it's a bit cloudy, but the other issue is that the purity of this medication is about 98% CBD approximately. So it still contains a little bit of THC, less than 0.015% has been estimated. maybe some traces also of cannabinoids and terpenes at the dose of 10 milligrams per kilogram per day. So it's not 100% pure CBD. There's still some other components, and the other components are often what causes these kind of side effects. So I don't think that we have a clear picture that these side effects from this study are purely from CBD alone, because there's a little bit of some variable issues there. So the half-life of CBD, chronic oral use, when you're taking it by mouth, is about 2 to 5 days. The spray, there's an oral mucosal spray, about 1.4 to 10.9 hours has been found. Vaping or smoking is about 31 hours for the half-life, and then IV forms are about 24 hours. It takes about 2.5 to 5 hours to Tmax, to maximum concentration, when you take it by mouth. And metabolism is primarily through the liver, and specifically through the cytochrome P450 system, even more specifically the CYP3A4 and 2C19 enzyme systems, as well as a few others as well. But it's important to know that CBD acts as an enzyme inhibitor at these enzymes. So this can actually induce some CYP enzymes with chronic use, some kind of like some of the anti-seizure medicines. But the most important point here is that it acts as an enzyme inhibitor. So CBD can act by preventing those enzymes from breaking down other medications, and that can lead to an elevation of other medications. So the medications to be concerned of, and there's a lot of medications that go through these common systems of metabolism, so it's important to know that. But warfarin, Coumadin, for example, goes through the system. So you don't want to increase elevation of Coumadin with this, potentially, theoretically. Calcium channel blockers, benzodiazepines, many antidepressants and antipsychotics go through these, and there's a wide number of medicines that go through these. So it's just an important thing to keep in mind. It's suggested, at least from the Epidiolex studies, that you should decrease the CBD dose when you're using strong 3A4 and 2C19 inhibitor medications. You should increase the CBD dose when you're using strong 3A4 and 2C19 inducers, which makes sense. And then there's some other substrates as well that you can look at the Epidiolex data and information. I'll kind of give you a little more information about that. So with CBD pharmacokinetic and safety data from Epidiolex, which is great to finally have, the question is how much of this translates to more commonly used over-the-counter options that most patients are using. The CBD dosing in the Epidiolex was significantly higher than what you're going to find over-the-counter strength-wise, and it's not purely CBD. It's very close, but a lot of over-the-counter stuff is certainly not pure either. The dosing threshold to interact with these P450 liver enzyme systems is a bit unclear. It's likely that much higher doses are needed than what you're typically going to get in over-the-counter strengths, but this really needs to be looked at, and we don't have a clear answer yet. The Sativex studies, which is a whole plant CBD-rich sublingual spray, found no interactions with the CYP liver enzymes at 40 milligrams CBD dosing. But it's a bit of a gray zone. So it's something just to be aware of until we define this a little bit better. CBD has been questioned whether it has influences on the hemodynamic effects of blood pressure and heart rate and these kind of things. There was a study looking at 0, 400 milligram, and 800 milligram doses of CBD, and this study found no significant differences in any vital organ parameters, including respiratory rate, heart rate, or blood pressure. There was a single-dose crossover study of CBD looking at 300, 600, and 900 milligram doses. There was, again, no effect on blood pressure, regardless of the dose. There was a very slight increase in heart rate at 900 milligrams, but no effect on the 300 or 600 milligram doses. So overall, there really seems to be no significant effect on hemodynamics with CBD. So let's move into the legality of CBD use. Up until December of 2018, CBD was still considered a Schedule I drug because it came from cannabis. The Agricultural Improvement Act, or better known as the Farm Bill, passed in December of 2018, changed this. And so what this did, this federally legalized the agricultural growth and the use of hemp Hemp meaning cannabis strains containing less than or equal to 0.3% THC. So it legalized use of these products as long as the THC level is at 0.3% or less, and other hemp derivatives, the main one being CBD. It removed hemp and CBD from the Controlled Substances Act, so this no longer is an illegal substance under federal law. States may still vary on their CBD laws, so it's important to look at your state laws. In May of 2019, the TSA allowed travel with CBD products as long as that THC content is less than 0.3% or other FDA-approved CBD products. In Ohio specifically, the Senate Bill 57 passed in July of 2019 mirrored the federal program in that it legalized the agricultural growth and use of hemp and hemp derivatives, including CBD. And the important point here is that cannabis strains and CBD oils that contain greater than 0.3% THC are still considered marijuana. They are still considered federally illegal. You need a medical marijuana card for use, and it's illegal to cross state lines with anything containing greater than 0.3% THC. If you get caught with this stuff, even cannabis strains, some oils, there's a potential for prison time and large fines, legally speaking. So with the change in federal policy, we've seen an explosion of CBD products in everything. You can find CBD-infused beers, soft drinks, toothpaste, sunblocks, cookies, pastries. People drizzle it in ice cream. You can find it in CBD pillowcases, shampoos, conditioners, coffee. It's literally everywhere. So there's been a lot of confusion about what's real, and let's break down the over-the-counter CBD products. This will make it a little easier to understand the options out there. So there is, first of all, a CBD product called Full Spectrum or Whole Plant. There's Broad Spectrum, and then there's CBD isolate products. So there's three main categories. The first one, the Full Spectrum or Whole Plant, is the most popular. This is most likely to provide those entourage effects. And this contains everything that the cannabis plant contains. So it contains CBD, but it also contains trace THC, which should be less than 0.3% by federal law, terpenes, flavonoids, the other components of cannabis. Broad spectrum CBD products are full spectrum minus the trace THC. And then the newer product out there is CBD isolate. This is CBD isolated from all plant contents, including trace THC. It's important with all these products, though, if you get drug tested for THC, it's unlikely that these are going to show up because the content is so small if it's a good product, but the risk is still there. So it's still potential to show up THC positive. So it's important to know what you're getting, to get a good product that's been tested and you know exactly what's in it, because you don't want to show positive on a drug test, by accident with these kind of products. So the 2018 Farm Bill preserves the FDA's authority to regulate products containing cannabis or cannabis-derived compounds, including CBD. Currently, there's no FDA regulations of quality control or dosing standardization. These are pending, and they are really necessary. In the meantime, until we get those regulations, it's important that if you're using a CBD product, you want to use one that includes independent third-party laboratory testing for content and quality. And there's a number of good brands out there that have this, and you can see this on their websites. And it's important to make sure that these are third-party independent laboratories that are confirming the content of the CBD products. And let's go over some of the reasons why. There's a big concern of over-the-counter CBD product safety issues. So there was a big study done in Journal of American Medical Association in 2017, which looked at 84 CBD products analyzed from 31 different companies. And this looked at 40 oils, 24 vape liquids, and 20 tinctures. And they looked at the CBD content overall what was in the label and what was actually in the product. And essentially, about 70% of these products were inaccurately labeled. So a lot of them had inadequate amount of CBD. About 26% had less than what they advertised. The other concerning thing is that high THC levels were detected in almost 22%, 21.4%. So, these are levels that are much higher than what's federally legal. So if you get caught with this stuff and it actually has a high THC, that could really legally expose you to some risk. CBD content was looked at between product types as far as mislabeling goes. The most commonly mislabeled products were the vaporization liquid. So 88% of these products were labeled inaccurately based on the advertised versus the actual amount of CBD in these. Tinctures, 75% were inaccurate, and CBD oils, 55% of these specifically were inaccurate. So more than half did not have the amount of CBD that they advertised, which is a bit concerning. There was another study, smaller study, looking at 13 CBD products tested across Los Angeles and New Jersey. 5 of these products had no traceable CBD at all, so almost half had no CBD, even though they were selling as CBD products. 2 of them had very high THC, 3 milligrams, which is a significant amount, which would probably give you some psychoactive effects. It's really supposed to be 0 milligrams, and so it's a significant amount. One of the CBD gel caps actually contained a deadly strain of E. coli with the Shiga toxin. 2 of these had potentially dangerous levels of ethanol in them. And there was a breakdown of the other products as well. So it's quite eye-opening and quite concerning. In 2017, there were 5 patients in Utah that developed seizures, confusion, coma, hallucinations. Many of them had to be in the intensive care unit, intubated, and they were using a CBD product. 52 patients were harmed through 2018 with this product, and it turned out that this CBD product, what it was selling, as at least, actually contained a synthetic cannabinoid with no CBD at all. And these are very dangerous substances. The International Cannabis and Cannabinoid Institute in the Czech Republic looked at 29 CBD products. 69% of these exceeded the recommended levels of polycyclic aromatic hydrocarbons. Now, these are carcinogens. These are genotoxic mutagens, according to the International Agency for Research on Cancer. So there's concern with, a lot of bad stuff in a lot of these products of CBD that are just not regulated, which is why we need better regulation. And there's concern also that some contain pesticides, heavy metal contamination, so things that are important to be aware of. So what about dosing and clinical use? The primary routes of administration are orally, primarily through oils, tinctures, vaporization, or topical forms. It's suggested, maybe starting between 5 to 20 milligrams per day, divided once a day to 3 times a day, titrating up to effect. These are mostly the doses you're seeing over the counter, 5, 25 milligrams. Honestly, it's not clear what dosing is needed or most useful. And a lot of these products, my guess is that they're too low to probably even do a lot for you. The suspicion is that higher doses, like, in the hundreds milligrams, are likely needed for pain and inflammation. We don't have any evidence for this. This is just based on limited scientific data out there, but it just needs to be looked at and confirmed because we don't know the correct dosing or what's going to be most effective yet. We will. So there's no established dosing guidelines or maximum doses right now. 400 to 600 milligrams per day showed benefit in social anxiety for public speaking in a small study. Doses of 600 to 800 milligrams per day showed benefit in psychosis. And up to 2,500 milligrams per day, or 25 to 50 milligrams per kilogram, have been used throughout various epilepsy studies. So there's been a number of misconceptions as well with CBD. I want to just kind of hit on some of those here. One is that CBD is a non-psychoactive and non-psychotropic substance. The reality is that it's better to call this a non-intoxicating substance And this is really more accurate because it does seem to have potential pharmacological benefits on anxiety, psychosis, schizophrenia, seizures, possibly depression. These are all things being looked at. It lacks reinforcement, craving. It lacks compulsive use. Misconception number 2 is that CBD is sedating. The reality is that low to moderate doses are actually alerting. So some patients are using these in morning coffee, this kind of thing. Early anecdotal literature involved CBD, which also contained other sedating components because it was really full spectrum products. So these products also contain trace THC, other cannabinoids, other terpenes. These things all can influence sedation as well. Myrcene, for example, is a terpene which is attributed to the couch lock phenomenon that you get in certain cannabis strains. And it's a common terpene found in these products. So these are more likely what was suspected to be a sedating substance rather than CBD itself. There's been numerous more recent studies looking up to 600 milligrams of pure CBD, which did not report any sedative side effects. Again, it needs to be studied better. Another misconception is that CBD is a CB1 antagonist or a CB1 blocker. We kind of hit on this earlier. The reality is that it is what I mentioned earlier, a negative allosteric modulator at this receptor. So it's a non-competitive CB1 receptor blocker. So it doesn't attach to the same receptor as CB1. It actually attaches to another that influences that receptor. And so many have erroneously compared this to a medication that was in Europe for a short period of time called rimonabant. This was a selective CB1 receptor blocker, attached to the CB1 receptor directly. And it was an anorectic anti-obesity drug, but it was withdrawn in Europe due to it was having a lot of serious psychiatric side effects, suicidal ideation, anxiety, depression, these kind of things. So, the point is that CBD does not work at exactly the same receptor mechanism that this kind of medication did. Another misconception is that CBD turns into THC in the body. CBD was converted into THC after prolonged exposure to simulated gastric acid in a study. This isomerization reaction with strong acid has been known for decades. The reality is that there's no evidence that exists that shows this reaction occurs in vivo in humans. There's no known enzyme that exists to catalyze this kind of bioconversion. Pharmacokinetic and metabolism studies in human clinical trials actually refute this. So this is really felt to be untrue and not a concern. So in conclusion, CBD shows analgesic and anti-inflammatory effects in scientific and animal models, but there's limited evidence currently that exists in human studies. So we certainly need this, and personally, I'm hoping to get this study going very soon for migraine prevention with CBD. Non-FDA approved forms of CBD may have inconsistent levels of CBD, THC, other contaminants, and adulterants. So it's important to keep this in mind because you want to use these things safely. Non-FDA approved forms of CBD should be from companies using independent third-party lab analysis, clarifying and confirming what is in the product that you're using, at least until we have some FDA regulations released to guide these kind of standardization procedures. And CBD involves drug interactions with some very common hepatic enzyme systems. The dosing threshold for interaction at these systems is still a bit unclear, but it exists, and so it's something to be aware of. It more likely requires higher doses than what you're getting in over-the-counter versions of CBD products, but again, we just don't know yet. We need to have evidence confirming this type of information. If you have any questions about any of the references that I talked about, feel free to comment, and I will post those up for you. There's a lot that we still need to learn about CBD. This is really a new science, a new scientific field, and we are gaining knowledge slowly. But I think that now that we have this federally legal pathway of CBD as of December of 2018, I think that we are going to see an explosion of CBD studies for safety reasons, for a wide variety of medical uses, to really get better evidence of what is the benefit of CBD, what can you truly get from it, or what does it actually not do. And so we're looking forward to getting those answers. As we get more information, I'll certainly update this talk. I have separate talks that I'm going to post up with specifically for medical cannabis and a variety of other top educational topics, as well as I'll be posting up a variety of procedures done on patients to guide you through different types of blocks, such as Botox for chronic migraine, occipital nerve blocks, auriculotemporal nerve blocks, and a variety of other things. So those things will be forthcoming. But feel free to comment if you have questions, issues. I'm happy to answer whatever I can in the comments. Okay. Thank you for listening, and I appreciate your time. Talk to you later. Bye.